Welcome everyone to today's webinar. My name is Shauna Cooper and I'm the Director of Programs at Ribbon. We have an exciting webinar presentation for you today and a dynamic speaker who I had the opportunity of meeting a few months ago at IAS in Munich, Dr. Monica Gandhi. She will be presenting on the topic HIV Aging, Syndromes, Programs, and a Path Forward. A little bit about Dr. Gandhi. He is a professor of medicine and associate chief in the Division of HIV, Infectious Diseases, and Global Medicine at the University of California, San Francisco. She's also the director of UCSF Center for AIDS Research and the medical director of the HIV Clinic, Ward 86 at San Francisco General Hospital. She serves as the associate program director of the Infectious Diseases Fellowship at UCSF. Her research focuses on HIV treatment and prevention optimization, HIV and women, adherence measurement and HIV and TB, adherence interventions, and on optimizing the use of long-acting ART. Without further ado, I'm going to turn it over to Dr. Gandhi. Thank you all for your time, and thank you, Dr. Gandhi, for this presentation that you're about to facilitate. Thanks.
Okay, great. Thank you. So I'm going to talk about the title of this talk is HIV and Aging, a Path Forward. And let me just put this on presenter mode. So, I wanted to talk today about the pathophysiology of HIV and those living with aging and those living with HIV, the aging of the epidemic, talk a little bit about comorbidities and some clinical care programs. And I want to leave plenty of time for questions or thoughts and everyone to talk. So I'm going to try to get this done in a period of time so that we can have that discussion. So, one of the first studies that showed that essentially there is what we call accelerated aging in those living with HIV was the SMART study. And this was published now in the New England Journal in 2012. And what happened was at that time, the medications were really hard to take, the HIV medications. So we were always giving people breaks off the HIV medications. And the strategy here was breaks off and on of the HIV medications versus a steady using them all the time. And what we thought we'd see is that since the medications were so hard to take and they could cause comorbidities, that we'd have better HIV outcomes in those who took the medicines all the time, but worse comorbidities like heart disease or liver disease. But actually, it was totally the opposite. What happened is everything looked better if there was medications taken every day, no matter what your T cell count was. And that really led to the idea that HIV itself is what's causing the chronic inflammation and the elevation in risk of cardiovascular disease and other conditions. It's like having the flu all the time, like just having a virus replicating in your body is not good for the health of your arteries and veins and essentially just keeping that HIV viral load always undetectable is the best thing even for aging. And if that was one of the first studies, that kind of launched the entire agenda, the kind of research agenda on studying inflammation and how to get that inflammation down. And the best way to get that inflammation down is to take HIV medications and be virally suppressed. There's just no doubt. So this was depressing, I thought, in Munich to see that there were not many changes in the HIV incidence and deaths across the world. This was the data from 2 years ago. This particular UNAIDS report 2 years ago in 2022 was called In Danger, because that's how worried UNAIDS was about our setbacks in the HIV response. Unfortunately, if you look at those two numbers of incidents, 1.3 million new infections a year, 630,000 deaths, there was zero difference in those two numbers in the 2024 update presented in Munich from UNAIDS. Those same incidents, the same number of deaths, even higher numbers of people living with HIV, way above 40 million if we count in Russia to this 39.9 million, which didn't include data from Russia. And only a 72% suppression rate of those living with HIV. So meaning not everyone's on treatment, not everyone's diagnosed, but importantly, it's hard to take those pills every day, and we haven't gotten to where we want to be with virologic suppression worldwide. And I think these setbacks are really a function of everything on this slide. I think it's, um, reduced AIDS funding. We've had an 8% AIDS funding cut in the last 3 years. It's stigma, worsening stigma of all things, more discrimination, more social inequalities, anti-homosexuality laws, anti-LGBTQ violence, anti-trans rights, violence, conflict, wars, putting our money into weapons and not into healthcare. I think there's really some very clear reasons why AIDS is having these setbacks, and I think it's really disturbing, and it's up to us as HIV advocates and HIV providers and treaters and people living with HIV to fight this. So in terms of the aging epidemic, not that the UNAIDS updated that, but we just know that people are living longer with ART. And absolutely in the US, 50% of people are over the age of 50. So we have an aging epidemic in the US, but also even worldwide, that there's in 2022, there's just more, and that's our latest data. There's just, you can see this right going to the right in terms of the demographic curve, more people who are older, even worldwide. And so that means we have to pay attention to HIV and aging, and we had to pay attention to these syndromes of aging. These are all the syndromes. It's heart disease, it's bone loss, it's lung disease, it's getting diabetes, it's more frailty, there's cognitive disorders, there's liver disease, there's renal or kidney disease, and weight gain. And these are the diseases of aging for anyone, actually, but it's accelerated in those living with HIV that we have to combat, and that there are ways to combat almost all of these. And that's what's important. We don't have to sit down and say there's nothing to be done. There are ways to work on every one of these aspects of care. So I wanted to tell you about our program at Ward 86 because I think we've tried to tackle it. I don't think we're there yet. I think we're getting there, but the Golden Compass program is something we started as a designated program for those living with HIV who are older. And the way we started this program was not just to kind of do it without thought. We had focus groups. We looked at the data. We looked at lots of things sort of together, literature review to come up with a thoughtfully designed program. And our designed program, first we did a city needs assessment. This was way back, 2013. We had forums with long-term survivors. We have community long-term survivor groups here in San Francisco. And we also looked at the literature. And these were the syndromes that made the most difference, were on people's minds that they really needed help with. And that was pre-frailty, depression, cognitive impairment, or just difficulty with those kind of activities of daily living. So we took those, very, and visual impairment actually, and we took those biggest needs and we put them into the design of our program. And when we did a survey of people who are older living with HIV, you could see that there were high rates of having a fall in the last year, having dependency and needing help with those activities of daily living. Loneliness was absolutely a feature, not being as cognitively there as we felt like we were in the past. And we took all those into account when we designed this program. And then we also ensured that we looked at medications, because one thing that can happen when people are older is everyone keeps on adding on medicines, and sometimes they need to be reduced, and sometimes the doses can be reduced because people are getting older and they don't need those high doses. So having a major part of polypharmacy and medication evaluation in our program. And putting that all together, we also looked at what providers think was the biggest worries in people who are older, and they were kind of the same things that were coming out: falls and memory and depression. And then we had the provider focus groups and the patient groups, and from that came more ideas. And the focus groups were really important because people really had ideas about what it should be called. They liked the name golden as opposed to silver. They thought it was warmer, and they had ideas about what should go into that program. And this was the ultimate design of our program. We call it a compass. A golden compass is a book, and we call it the Golden Compass. And there are 4 points to the compass. And if you look at those 4 points, the northern point is heart and mind. And what we mean by that is we have cardiology care, designated cardiology care, and we have a cardiologist on site. We're trying to find a new one because our one's just left. And then we had we had a mind component. So that's having a cognitive expert come in and do kind of, there are things that you can do, puzzles, like sort of crossword puzzles, other things that are that stretch our minds, that help with cognitive improvement. The Eastern point was bones and strength, because strength, frailty, getting stronger, doing chair exercises, getting up from the chair. Also things like bone density and doing bone density scans and treating lower bone density is really important. People are older. The Southern point was network and navigation. So we have groups, we have walks during the pandemic, and now we go back to groups with food. And it's a lot of social talk, but there's a lot of also people coming in and saying, how do you do your DPOA paperwork? How do you do your will? How do you do your estate planning if you need that? Like what can we do to help you with all that networking of life, including the social support of the groups. And then because hearing and dental and vision are so important, the Western point is actually navigation to those really important services, audiology, vision, and dentistry. And putting that all together, that's our Golden Compass program. And we did a lot to actualize it. We got an HIV cardiologist on site. We got these brain health classes. We wrote a grant and got a DEXA machine. The DEXA machine is what allows us to measure bone health. We got a designated pharmacist to help with polypharmacy. We got a geriatrician on site every other week now. It used to be every week. That was better. And we got all the services lined up so we can navigate people to hearing and vision and audiology. And then we worked with community agencies around the social support groups. And it is working. I think that one framework that was really helpful was to think about what are called the geriatric 5Ms, and geriatrics always knew this, that they had these kind of 5 components of older people's healthcare that really matter. One is your mind, one is mobility, one is medications, decreasing and also maybe decreasing doses. One is multi-complexity, and also what matters most. Maybe you don't want a colonoscopy at age 78. What matters most is something different instead of screening for colon cancer. So what matters most to you? And all of that was the framework of the establishment of the program. And we're always trying to refine it. For example, we think weight gain is a big deal right now. So we are just talked to the head of the division of endocrinology last week to say, I think we need an endocrinologist on site to help us with weight gain, with statins, with metabolics, with diabetes, with just all those kind of endocrine issues to really improve the health of people living with HIV who are older in our program. So we're always trying to change and update. And in terms of that weight gain, because I think that's worth mentioning, that even though we're at a point in the epidemic where we really are using integrase inhibitors, that's just first-line therapy worldwide, and they work really well, but there is an association with the second generation integrase inhibitors. Those are dolutegravir and bictegravir with weight gain. And now that we've had them since 2013 for dolutegravir, 2018 for bictegravir, we're seeing that weight gain. And the question is, where was that data most pronounced? It was actually in the advanced study, which compared dolutegravir TAF FTC to dolutegravir TDF FTC, the older tenofovir, to efavirenz TDF FTC a long time ago. That's the regimen we used. And dolutegravir looked great. This was in sub-Saharan Africa. It was in South Africa. It looked good for virologic suppression, but it did lead to increased weight gain, especially among women. And that's translated for BIC-TAF FTC as well, which is really commonly used as a single pill combination in this country. So that increased weight gain can have metabolic effects. And the question is, do we work with exercise and nutrition, which can be hard to do? Do we use GLP-1 agonists, which we do have access to in the United States? Or do we think about changing the antiretroviral therapy? And that latter question is a very active area of debate and study in HIV medicine. Do you change the HIV medication? Do you take off the TAF and bring it back down to TDF, that TAF, which was supposedly the safer form of tenofovir? Should we go back to TDF? Well, the Characterize study would tell us that yes, when they took patients on dolutegravir TAF and put them back to dolutegravir TDF, they did lose weight, especially women. So that's one strategy that we've been thinking about. The other, actually, that data came out of the Munich meeting a couple of weeks ago. a couple of months ago now, which was to look at maybe we should think about big TAF FTC as a big culprit for weight gain. This was a study where patients were suppressed. They were all doing well on whatever they were doing, and they got switched over to big TAF FTC. Again, a very commonly used HIV medication here versus dolutegravir 3-TC. And they did see higher rates of weight gain in those who got put on big TAF FTC. So it's a true phenomenon. It is happening. Do we again take away the TAF? Do we go to dolutegravir 3-TC if there's no mutations in the past? It's just something to think about. And I will say that we are starting to strategize at Ward 86 about not always reaching for big TAF FTC as our first line, or thinking about changing it if people gain weight. And we need more data on this and which strategies would make people lose weight. What we do know is that statins are important. Statins are those cholesterol medications, and the Reprieve study was published in August of 2023 that said if you randomize people with HIV to statins versus not, what happens in terms of adverse cardiovascular events. And yes, if you're on a statin, there was a reduced risk of major adverse cardiovascular events, and it was significantly reduced. And weight gain does increase your risk of cardiovascular events. So statins, for anyone who needs them, anyone who's at least moderate risk for heart disease, is a must in people living with HIV. And that's if you're not on a statin and there's risk factors, that has to be discussed. And then finally, reducing your viral load, having virologic suppression is the goal for everyone living with HIV, getting down to that virologic suppression, that undetectability of viral load. And if it's too hard to do it with an oral pill, then we have the long-actings. And we have been studying at Ward 86 using long-acting antiretroviral medications. Those injectables, there's only cabotegravir and rilpivirine that we have for injectable therapy. But using those injectables in people even who absolutely can't take an oral pill. Now, the studies were only done in those who took an oral pill and were virologically suppressed, and then they switched over to long-acting. But we have been studying at Ward 86, just using that long-acting antiretroviral therapy right off the bat, even if you have high viral loads, as long as you can come into clinic for those injections. And we've published on this data. In fact, we have a very rigorous program. We call it the SPLASH program. We meet every 2 weeks. We say, anyone that we're worried about on long-acting cabotegravir and rilpivirine, we have 300 patients on this regimen out of our 2,600 patients. We're getting used to it. We're good at giving these injections. And we've published both in this piece, this was published about a year ago, that shows that even if you start with viremia, even if you're homeless, even if you're using stimulants, even if other aspects of life are so hard, taking that injection instead of the oral ART really does lead to high rates of virologic suppression. And what I mean by that is of the people who started with viremia, and we updated this data at CROI 2024, of 59 people who started who had high viral loads. By the way, they also had low T cells, because if you have high viral loads and you don't take medication, you can get into that danger territory of having low T cells. But we showed that patients who started with viremia still persisted over 48 weeks with high rates of virologic suppression on the long-acting cabotegravir and rilpivirine. So it really, really seems to work to use long-acting. And our efforts and other groups' efforts has led IAS USA guidelines to say, let's use these medications in patients who are at risk for disease progression and have viremia. And we're very happy that the IAS USA guidelines changed their recommendations to use this in people who have a hard time taking the oral pills. DHHS has not changed it, which is our other guidelines committee here, but we're happy that IAS USA did. The other thing I want to talk about next is really about prevention, because age is not a condom. People should have all that intimacy that they want into later life, but it can put people at risk for HIV. I have a recently diagnosed patient in my clinic who is older, and she did not know about, unfortunately, about HIV prevention. So the HIV prevention that we really have is the oral pill. It's really oral daily TDF-FTC or TAF-FTC, but we're getting into these long-acting agents for HIV prevention. And they can be safer because any tenofovir pill, whether it's TDF or TAF, can lead to effects on kidney and bone. And so we're getting excited about these long-acting HIV preventative agents, and one is cabotegravir and one is lenacapavir. And the reason to talk about lenacapavir is the data from HIV prevention at AIDS 2024 on lenacapavir was such a big deal. It was absolutely the focus of the meeting. And this was the Purpose One study. Now, this was a study not done in older people, so that's very, very clear. We have to say that this was done among cisgender women, and it was younger women. In fact, the design of the study was looking at lenacapavir, which is such a potent agent that it can be given every 26 weeks, every 6 months, essentially, as a subcutaneous injection under the skin. And it was lenacapavir every 26 weeks versus daily oral TDF-FTC versus daily oral TAF-FTC. That was the design of the study. And it was really important to say as well that it was a young women's population. It was if you look at the women enrolled in the study, and there were over 5,000, the median age was 21, and there was a lot of STD risk, lots of chlamydia, some gonorrhea, and that just means that even though PrEP was widely available and free in Uganda and South Africa, that oral PrEP wasn't something that the women really could incorporate into their lives. And so it's already saying that stigma and other reasons made it hard to take oral PrEP even when it's free in these countries. So this idea of another option was really important. And you all know the results of this study because really lenacapavir, at least in the duration of time of this study, maybe when we go longer, we'll see some HIV infections, but the duration of time of this study, there was no infections in the arm of those who got lenacapavir versus a certain risk of HIV in those who got the oral pills. And it raised a lot of attention at AIDS 2024. How hard it is can be to take oral pills was one thing that it raised. The nodules that lenacapavir causes, because it's very common to get nodules right under the skin, and whether that's going to be a barrier or not, it wasn't in the trial, but this is a clinical trial. It's not the real world. And it also raised the issue of accessibility of this drug worldwide. And there were so many in the global village outpourings of protest and of commentary that we really can't get these long-acting medications and not make them accessible in low and middle income countries and to everyone who needs them worldwide. And I think there's going to be a big onus on the regulatory industry and the pharmaceutical companies to make these accessible. So I actually wanted to end there because I really wanted to have us have time to have questions. I've talked about treatment and the INSTIs, great drugs, but what we need to think about is really a long weight gain. I've talked about prevention, and we're in that era of long acting and how exciting that is. And I've talked about comorbidities and how important it is, especially with statins, but other ways to control the comorbidities. And then I've talked about a very designated specific program that we have at Ward 86 to treat holistically people who are aging with HIV. So let me stop and get your questions and thoughts and commentaries and everything else that we'd like to talk about.
Sure, and thank you so much for that great presentation, Dr. Gandhi. We do have a question from Michael Luciano. He says, how are you
Great.
defining high viral load for initiation of LA-CAP and non-suppressed persons living with HIV less than 100K? Like, how are you defining that? Michael, if you care to elaborate more on that, feel free to.
No, I was just curious what data point you had set as to distinguish those 59 that you said started with a higher viral load. Are you using greater than 100,000 copies per milliliter or?
Well, so we have no barriers to starting long-acting cabotegravir rilpivirine. What I mean by that is that right now the FDA package insert for cabotegravir, based on what trials led to its approval, which are called FLAIR, Atlas, and Atlas 2M, the FDA package insert says that you should use cabotegravir and rilpivirine if you're virologically suppressed on oral ART. virologically suppressed, undetectable, less than 50. So we have kind of gone outside that box and said, no, we think that these injectables are really important for those who have a hard time taking oral pills. We've been waiting till 2021 to get them, and we're going to try them in all ranges of viral loads. So for example, the patient that I first started on long-acting cabotegravir and rilpivirine in our clinic who wasn't virologically suppressed was my patient, and his viral load was 1.3 million. Sometimes the viral load is 20,000, sometimes it's 1,000. It's just a whole range. Our point is we do not use viral load as a criteria for the use of long-acting Cabril. And luckily our data and other data, including the, somewhat the 5359, I can go into that because that didn't look at viremic patients, but our data really did contribute to IAS USA guidelines saying go ahead and use it in those who have viremia.
Thank you.
And since we have a small group, if you just like to raise your hand or come off the mic and ask a question or make a point, that would be appreciated.
Yeah, hi, Dr. Gandhi. Jeff Berry here.
Hi,
Great presentation. Thank you.
thank you.
I like how you included prevention, when you're talking about older adults and HIV and aging. Even though these are people who aren't living with HIV, it's going to take a concerted effort to focus on this population and do it in, innovative ways because, as 15 to 20% of new infections or new transmissions are in people over 50. So, and there's that great Age is Not a Condom campaign, but there aren't a whole lot of campaigns. So I always advocate for that whenever I can. And I know you do as well, but I also liked, how you talk about treating holistically people aging with HIV and how
Yeah.
that's part of the clinic, the Golden Compass Clinic. But that's one clinic, and we need a Golden Compass in every city, in every town, and every place where people with HIV are, and which is everywhere. So do you have any recommendations on how like a community might even start to advocate for that in their research centers or CFARs or their, whatever their leading organizations, the importance of holistic care and person-centered care and meeting the patient where they are, I guess.
Yeah, I mean, it's a really, really good question. We did not need that many resources to start Golden Compass. So that's the other thing is that if you put your mind to it, you can do a lot of this kind of with current resources because Medi-Cal and Medicaid and then Medicare, for those who are older, did pay for example, the heart care, getting the cardiologist on site. We just said, we need a cardiologist on site, and then we build insurance. They did pay for the DEXA scans because it's absolutely within guidelines to do the bone health screening, and they did pay for the geriatrician. So the kind of things that we had to get extra resources for was the cognitive person to do the brain health classes. We also do narrative medicine and writing out people's stories. That was a resource. That was like getting discretionary money to actually pay that person and also do chair exercise classes. And then the second one was the social groups. And the social groups, we used our social workers on site, and we just got some money from a pharmaceutical company to get food, which is important for any group is food. So it didn't end up, you just had to kind of put your mind to it, I think. And I have to brag for Ward 86. That's a very Ward 86 thing. We just put our mind to it and we do it with little resources. And then by showing that things are working, you can apply for grants and get more resources.
Thank you. And then is there an evaluation component with people who access the clinic, and what are you finding as like the most pressing needs that they are telling you? Or
yeah, I mean, we have had evaluations that we published, and people like the program. I think they really like the social part of the program. And and uh and we've also seen good outcomes in terms of reducing polypharmacy, for example, or increasing bone scans, increasing frailty assessments, increasing home visits to look at the a place of residence and making sure things are safe. I just went last Saturday to my patient's home to look at her bathroom and to look at her throw rugs. I didn't want her to have any throw rugs because she had fallen, and we got rid of those, and we got her a chair, and we got her a bright light. She has had a history of CMV retinitis and she needs better lighting. And so we just do home assessments. So we have had really good outcomes, I would say, and people like it. And so just, contact us anytime. I would put you in touch with the kind of nurse who's leading the Golden Compass program to get kind of the elements of it and how to work it out in each clinic, in different clinics. We would love for people to replicate it.
Thank you.
I did want to let you know that I'm having a clinical issue, so I have about 10 more minutes for our call.
Thank you so much for that. Any other questions or comments for Dr. Gandhi? Yes, Michael. Luciano.
You specifically mentioned loneliness as an issue among people aging with HIV, which I think we've all seen reflected in our various patient populations and probably ourselves as well. And I was wondering how you address that. Obviously, that's more the social services side rather than the clinical side of the program. But did you design support groups specifically for patients 50 years of age and older, or 60 years of age and older? Like, how does your Golden Compass program try to counter that specific issue?
Yes. So we only that was another thing that came out of the focus groups, to only to serve people 50 years and older. So you can be 51, or you can be my oldest patient right now that I have is 79, and you can be in this program. And that was really that accelerated aging phenomenon that we wanted people 50 and older, but we don't let in anyone who's younger. They have other ways. And it's worked. Like, you can see that there'll be maybe a 55-year-old with a 75-year-old, but there are common issues, even though that's a pretty wide age range. And I've actually been really pleased. The social groups especially have gone really well. There are people who are dating, there are people who are not dating, there are people who are in couples, there are people who are like, hey, I have someone that I want to introduce you to. There's real, like, prescription and decisions about loneliness. Some people want to date, some people don't, some people just want this group, some people want friendships. It's working really well because it's all peer. It's not like someone coming in and telling people what to do. It's just people talking. And we have them weekly. We have them with lunch, and we have them in a conference room 2 floors down from our clinic.
So you actually have like a weekly social gathering.
Weekly with the social worker for Golden Compass leading it.
Thank you.
He's an older gay man himself.
And Dr. Gandhi, thank you for your question, Michael. We have 1, possibly 2 more questions, and that should be it. Ed, your question, please.
Thank you. Thank you so much, Doctor. Very intrigued I left San Francisco a little bit too early. My question is along the lines of what Jeff Berry had asked. This is very interesting. I have no power here in New Jersey. I'm just a person living with HIV, but I'd be interested in putting the New Jersey HIV planning group in touch with you, or you mentioned the nurse that oversees the program.
Yes.
If you could just share with us information so that I can pass that along. I started an HIV and aging work group while I was on that committee, but it never really went anywhere because we were kind of floundering as to how to address the complexities. And what you've outlined here with this Compass program is inspiring. So I look
I
forward
do
to
think
getting
it's a
more.
very organized, holistic, makes sense program, and it's working. And yeah, we would be really happy. Just email me. This is my email in the chat, and I'll put you in touch with how to
Perfect.
get that.
Thank you so
We
much,
also work
Doctor.
through our San Francisco HIV Planning Council as well.
And I was a patient at the at USCHC at University of California, San Francisco when I lived out in San Francisco.
That is great.
So
Okay, well,
that was a
we
long,
miss you
long time
here.
ago. Well,
We
thank you
miss
so
you
much.
here. Thanks.
This is wonderful. I like that people are looking to replicate it in their areas as well. So thank you so much for this conversation. Dr. Gandhi, did we have one last question before we
Okay.
end this webinar? Did we have one last question? Are we good?
I'm looking at the chat and I think we got everything.
Okay, well, great. So on behalf of Ribbon, thank you, Jeff, Michael, Ed, other Mike, Debbie, and Alexa for joining us today. This has been recorded and will be shared on our YouTube channel and other formats as well. And as always, thank you, Dr. Gandhi, for a very informative, enlightening, and hopefully duplicative program that will be showing up in new areas.
Thank you so much for having me. Talk to you all soon.